leukemia, and really a pleasure to be here. It's really, I just love the science of this disease, and I love the technology, and I love to kind of learn more from y'all as we try to tell you what we know about this disease. Glad to be here today.
So moving right along, today we're going to be talking about diffuse large B-cell lymphoma and follicular lymphoma. Diffuse large B-cell lymphoma is the most common of the non-Hodgkin lymphomas types, and it is very aggressive. Without treatment, most people's survival rate is only 1 year. And we also are going to be talking about follicular lymphoma. There is some overlap, but follicular is an indolent lymphoma. Usually people may present and be asymptomatic. Sometimes it can progress rapidly, or sometimes it can last for years. They are managed differently. So we're going to split up this discussion. First, we're going to talk about diffuse large B-cell lymphoma. And the first question, Dr. Favaro, please would you share the current therapy for diffuse large B-cell lymphoma and at initial diagnosis, what you do with your patients?
Sure, absolutely. So just as a background to talk about this disease, I want you to try to imagine a cancer cell as a ball. I know this is a little simplistic, but if you think about a ball, in the middle of the ball is where all the DNA is. The DNA is a recipe for what makes a cancer cell what it is. There's 30,000 genes. This DNA in the middle of that cell is making all these proteins that make that cancer cell grow and make it do what it does in your body. And also as part of that, on the inside part of that ball, there are all these proteins. We're going to talk about some proteins today. These are proteins that circulate around the inside of that cell and they make the cancer cell grow. Things like BCL2 or MYC, BTK, these are proteins. On the outside of that ball, there are spikes. These are proteins on the outside of the cell. And we talk, my dog has this little ball with spikes on it, he chews on it. Think about that. These are all these different types of spikes on the outside of the cell. They're called receptors. And we can use those spikes and target cancer cells with our treatments. And so going back to the initial treatment for lymphoma, it goes back to 1976 when a combination of different chemotherapy was first approved, CHOP chemotherapy. It's a combination of 3 different chemotherapy drugs along with prednisone. And back in the 1970s, we were giving chemotherapy that really attacked and treated and killed all these fast-growing cells. It wasn't really targeted to these spikes of these proteins. And then about 20 years ago, we discovered this drug called Rituxan. And Rituxan is a targeted therapy. It's basically an antibody. It's a Y-shaped molecule, and it targets CD20, which is one of the spikes on the outside of the cell. And so we found that this is a great advance in cancer treatment. If we added Rituxan to all that chemotherapy, patients did better. You lived longer, had a much better chance of going into remission. And so R-CHOP has been kind of the standard first-line treatment for diffuse large B-cell lymphoma over the last 20 years. And then finally now we have a new advance. This is a drug called Polivy. Polivy is another targeted treatment, and it's another Y-shaped molecule. And the Y part, the end part of this molecule is binding to one of these spikes on the outside of the cancer cell. This time it's CD79. And so the most recent studies show that if you add Polivy to Rituxan, which hits CD20, and then also include 2 different chemotherapy drugs and prednisone, this is the new standard of care for the treatment of diffuse large B-cell lymphoma. And the studies have shown that, yes, the response rate and the survival is about the same with Polivy versus the old regimen. But it looks like at 2 years, the remission rate is better if you take the new regimen of Polivy plus chemotherapy. So that's the newest treatment for this disease.
Excellent. Now, unfortunately, even with these advances, which I think you're talking about a durable remission rate of 80% or so with the current therapy, but unfortunately there's 20% where perhaps it doesn't work. Patients will relapse very quickly. And Dr. Ghosh, would you talk about what happens in these patients who fail initial therapy? What do we have to offer them now?
Yeah, that's a really good question, and that has evolved certainly in the last 5 to 6 years. And so, in the past, the standard would be for patients who are eligible for an autologous transplant, they would get salvage chemotherapy, often chemotherapies like RICE or RDHAP or RGDP. And if they are chemosensitive, meaning if the tumor shrunk with that chemotherapy, then they would go for something called an autologous transplant, which is high-dose chemotherapy followed by giving them their own stem cells back. You know, as immunotherapy advanced, as we learned more about ways to harness the immune system to fight against cancers, this was applied a lot to diffuse large cell lymphoma. And a novel treatment, which you are very familiar with, CAR T cell therapy, came about. And, you know, initially it was approved after 2 prior lines of therapy, meaning patients would have had to gone through usually a transplant, and if it failed after a transplant, they would get it, or if they just got chemo and then they got it as 3rd line. But then, knowing that was very powerful even in the 3rd line setting, there were some randomized clinical trials directly comparing it with transplant. So, you know, there were 3 large randomized phase 3 studies which compared efficacy of and toxicity of CAR T cell therapy with that of autologous transplant. And 2 of those trials were positive in terms of, one, ensuring that the primary endpoint, which was free of disease, so progression-free or event-free survival, really, of, you know, that was better compared to transplant. And then one of those studies actually showed overall survival is also better compared to transplant. So the current standard of care, if somebody fails, and especially if they were refractory to frontline therapy, things like Dr. Favaro mentioned, frontline chemotherapies like R-CHOP or Pola-R-CHP or even R-EPOC, if they are refractory to that, or if they have relapsed within 1 year, then the 2nd line therapy would be CAR T cell therapy. One of the CAR T cell therapies called Lysocell was also used for patients who were not eligible for transplant, older patients, and also for, so even if they had late relapse but they were not considered to be transplant candidates, they could get Lysocell as a 2nd line therapy if they had some organ dysfunction which would preclude them from getting a transplant. So really in the 2nd line setting, I think we are thinking a lot in terms of CAR T cell therapy, reserving transplant for those patients who are late relapse but yet transplant candidates. They could get salvage chemotherapy, and if chemosensitive, go for transplant. If not, then still go for CAR T cell therapy.
So a lot of changes. And
a lot of changes.
I've had it all. So I would say stem cell transplant, you know, I joke around, 2 thumbs down, do not recommend. Yelp reviews are terrible. But anyway, it saved my life. But then I had CAR T, which was even better. So let's move on to follicular non-Hodgkin lymphoma. And I want to actually throw this out to Dr. Bono because this is actually very common. It is managed in the outpatient, and she's seen quite a few of these cases. And how do you manage these patients in your clinic?
Yeah, so thank you for that question. And you know, I agree with you. I mean, it's very common to see follicular lymphoma, and it's a different kind of disease process as compared with DLBCL in the ways that patients present. It's not the typical storm of presentation that you expect with DLBCL. These tend to be slower growing lymphomas, and they present in a certain way where most of the patients are even asymptomatic on initial presentation. They'll have scans for something else, we'll find lymph nodes that are enlarged, they'll have biopsies, and that's how we find it a lot of the times. And so the treatment tempo is a little bit different. The way to approach treatment is a little bit different when you compare it to a more aggressive lymphoma like DLBCL. And sometimes, you know, if we're thinking about stages like we do generally with lymphoma, the treatment differs based on what stage you are. So if you have a localized group of lymph nodes that are involved, a lot of times if patients are asymptomatic, we watch and wait. Sometimes if they have symptoms from this bulky lymph node enlargement, they can get radiation. A lot of times we'll combine that radiation with these CD20 monoclonal antibodies, like Dr. Favaro very nicely explained, targets these lymphoma cells directly. And so that is usually the options in limited stages of disease, stage 1 and stage 2. Now, as we're approaching more further spread out disease like stage 3, stage 4, even in those cases, a lot of folks, if they're asymptomatic, have a low burden of disease, we tend to watch and wait. That is still an option. Broadly, follicular lymphoma also is divided based on its grade, meaning not all follicular lymphoma comes equally. Some of the cases are lower grade, meaning the cells that are involved are not as actively dividing and do not appear as aggressive. And those we tend to steer more towards the watch and wait and kind of low tempo of therapy. The more aggressive varieties, the grade 3s and even grade 3s divided into 3A, 3B, we're looking more towards the DLBCL kind of treatment because these tend to be more aggressive and tend to act like a more aggressive lymphoma. So in that scenario, we're looking more at the chemotherapy plus immunotherapy options, where we're talking about rituximab plus the chemo backbone of 3 chemo medications with prednisone. And so I think that's usually tends to be the front line of therapy for follicular lymphoma. It's very varied. It's a broad spectrum depending on stage as well as grade, but it tends to be a slow-growing disease in general. And folks who get frontline treatment, some people get even rituximab with another medication called bendamustine, so not everyone needs multi-agent chemotherapy. And a lot of times we do a finite amount of chemo and then follow it up with rituximab maintenance for up to 2 years. Every 8 weeks they get a rituximab infusion, and that keeps patients in remission for a long, long time. But as we talk about the difference in the nature of the two diseases, follicular versus DLBCL, there's also a difference in the treatment goals for these diseases. So DLBCL is more aggressive, and as we were discussing earlier, we talk about curative approach. But follicular lymphoma, because of its indolent nature, we treat it, and there's a chance that it may come back, but we try to treat it to keep it under control for as long as possible with these milder therapies.
Excellent. And as a radiologist, there's a lot of CT scans and PET CTs involved,
Yeah.
where this is why you actually monitor the lymph nodes and if they're
Exactly.
increasing. So this is a field where, I'm a radiologist, so I do this. But sometimes, unfortunately, someone's in remission for 2 years, even 10 years, and then it comes back aggressively. And so then I would look back to you, Dr. Ghosh, what do you do with a follicular lymphoma that is aggressive, has failed all treatments, and then maybe even has transformed into diffuse large B-cell?
Yeah, so I think the first thing to think about when follicular lymphoma comes back is when it comes back. Okay, if it comes back within 2 years of chemoimmunotherapy, frontline, then it's considered to be this POD. You would have seen this word, progression of disease in 24. POD 24 means come back in 24 months.
Yeah.
And that is a more, even if it is come back as follicular lymphoma, it's a more, aggressive variant. And the typically in long-term studies, the survival for that type has not been good. So many research studies have focused on this POD24 group and try to see what treatments would be effective over there. The second thing to think about is what does it come back as? As we discussed, that follicular lymphoma can come back as low-grade follicular lymphoma, so grade 1, grade 2, grade
Right.
3A.
And that's based on pathology, the way it looks in the microscope.
Well, the importance is very in two things. One is on the PET scan.
Right.
So I think one of the important messages is that when it comes back, it's important to get a PET CT scan and try to biopsy the most aggressive or highest active lymph node, because a person might have multiple lymph nodes, and if you just biopsy one, it could be low-grade follicular lymphoma, but you don't want to miss another lymph node which has got high grade, because the treatment would differ. So get the PET scan, try to, of course, obviously convenience is important, and sometimes a high, very bright lymph node may be in an inaccessible site, which makes it challenging, but try to biopsy the most highest active lymph node. And then if it is aggressive B-cell lymphoma, then the treatment would be more to like DLBCL-like.
Right.
If it is low-grade follicular lymphoma, you would treat more with the low grades. So the timing of the relapse and the histology, so the biopsy. PET scans are good, I know you're a radiologist, but really the biopsy is where the money is.
Definitely.
So, put it under the microscope, let the pathologist tell us, what it looks like, and then decide, what to do. In general, in follicular lymphoma, since this part of the discussion is on follicular lymphoma, if it is a follicular lymphoma, then, there are many treatment options in the second line setting. A commonly used one, if Rituxan plus chemotherapy has been used before, is a lenalidomide or Revlimid based treatment in combination with a monoclonal antibody like rituximab or obinutuzumab as a second line treatment over there. And then subsequently, CAR T-cell therapy has been very effective in follicular lymphoma, as well as bispecific antibodies are also approved and very effective in follicular
So
lymphoma.
follicular lymphoma traditionally has been viewed as incurable, but now with CAR T-cell, there is now possibility of a cure. Is that correct?
Yes, so there is a possibility. The only long-term follow-ups we have with follicular lymphomas being curative is allogenic transplant. It's just because allogenic transplants have been there for decades. And follicular lymphoma can come back even, unlike unlike DLBCL, which doesn't have typically late relapses. There can be some, but usually relapses occur early in DLBCL. In follicular lymphoma, disease can relapse 10 years, 12 years later. So what that implies is that you would have to follow people for a decade plus to really be sure that the disease didn't come back. So perhaps even 2 decades. So CAR T cell therapy has not been there for that long, so we don't know for sure. But if you look at, there are hints though, because when I mentioned this POD24, the POD20 patients had frontline chemotherapy, and within 24 months their disease came back. We now have data that patients who were POD24 got CAR T cell therapy, and it's been beyond 2 years and their disease has not yet come back, which means the second line treatment was perhaps more effective than even the frontline treatment, which typically doesn't happen in cancer. So if that is there, then you're overcoming the bad disease biology. Of course, now at 5 years, if it doesn't come back, and then 10 years and 15 years, it doesn't come back. That's when with follicular we'll know. DLBCL, you can have quicker readouts, because if it doesn't come back 2, 3, 5 years, then you say, okay, likely cured. So
we have a CAR T support site that's online, and we have several patients who had follicular who are 4 and 5 years out from CAR T and in remission. So it's very encouraging. Moving on to exciting new treatments, we're going to talk about bispecifics. This is something that's happened in the last 4 to 5 years, I would say, and now some of them become approved. So, Dr. Farrar, would you actually talk about bispecifics, what's been approved, and how do they work?
Absolutely. So bispecifics are a fascinating field of medicine. The first bispecific that was approved was blinatumomab, which was approved for acute lymphoma, leukemia. This is probably about 5 to 7 years ago, and it was a very small molecule. And the way it worked was it was almost like a V-shaped molecule, and one part of the V would attach to your T cell, which is what's going to kill the cancer, and the other part of the V would attach to your cancer cell, and it kind of brings them together. And the T cell just goes ahead and kills that cancer cell just right there in that little location there. So if you flood your body with these little V-shaped proteins, you can see where you're bringing all the cancer cells next to your T cells, which are killing the cancer cells, and you can really get a lot of death of the cancer cells. The problem with that molecule was, and we still use it for acute lymphoblastic leukemia, is that it has a very short half-life. It's a small molecule and it would be degraded quickly, so you have to use continuous infusion and treatments in the hospital. So over the last few years, they've now developed better molecules that are more stable. So instead of a V shape, it's actually a Y shape. And if I could actually get my arms together, I could show you that. But the long part of the Y stabilizes that protein so it doesn't degrade so quickly. And so these Y-shaped proteins, they still do the same thing, bringing the cancer cell next to the T cells are now actually now available for patients for treating lymphoma. And so there's 2 that are approved for diffuse large B-cell lymphoma. These are for patients that have had at least 2 prior treatments for diffuse large B-cell lymphoma. One is called Epkinly, and Epkinly is a subcutaneously administered drug, and it attaches to the T cell, and the cancer cell brings them together. And what they're seeing is very high response rates in the order of 60%, almost like 80% in some cases, where 80% of the patients that take this drug, the lymphoma shrinks down, and even up to 60% will have a complete response where the lymphoma completely goes away. So it's a great new treatment. So they're actually given subcutaneously. There's a step up. So what happens is when you do this, you bring all these CAR T cells together next to the lymphoma cells, you got to get a lot of release of these cytokines and proteins in the body, and it can cause side effects, almost like you have the flu, fever, and it even get worse sometimes. You have low blood pressure. So we have to be very careful about how we dose these treatments. So we start with the low dose of an injection once a week, and you gradually bring the dose up. And once you get to that higher dose level, usually the side effects happen in that first month or so, and then you're just basically taking an injection once a month. That's a drug called Epkinly. There's another drug called Columvi. It's a very similar molecule. It does the very same thing. It's just given intravenously. So that's another where you step up the dose of that treatment over a period of about a month, and then you're actually getting IV therapy with Columvi every 3 weeks. And that's a limited duration of treatment. So for that particular drug, it goes out to about 12 cycles or 8 months of therapy, and then you stop. And the results we're seeing with these 2 drugs are that most patients will have a complete response. And you can see that be a long, durable, complete response. There's also a BiTE therapy that's approved for follicular lymphoma as well. This is a drug called Lunsumio. And this is given intravenously. similar step-up treatment, and this is given for a total of either 8 cycles if you go into a complete response or 17 cycles if you have a partial response. And we're seeing great results with that as well. So just kind of amazing technology, great responses in patients that have had at least 2 prior treatments for their either diffuse large B-cell lymphoma or their follicular lymphoma.
And this is performed as an outpatient,
It's outpatient,
correct?
right? So,
Yes.
so the way the treatment works is that there is a risk of this severe reaction. So in the early onset of the trials, most patients had to be admitted to the hospital after their second treatment or so, because when you step the dose up, that's when these side effects can happen. So for example, for Columvi, when you get the second dose, it's a little higher of a dose, and so you come in the hospital for 24 hours, and that's part of the package insert. But the other 2 drugs actually can be given completely as an outpatient. And we've got a protocol set up now where basically for Epkinly, you take the injection once a week for the step-up dose of that first month. And as you increase the dose, you're actually giving steroids before you get the treatment and for 3 days afterwards. And that seems to really reduce the side effects. And so for Epkinly, for diffuse large B-cell lymphoma, and actually for Lunsumio, for follicular lymphoma, those can actually be given completely in the outpatient setting. But there's a lot of education that has to happen because you have to understand what these side effects can be and how to manage them. So we really do a lot of education for our patients. And there's really 3 major side effects of those treatments. One is called CRS, and that's where you get a lot of these cytokines released as you're increasing the dose. And again, most of these side effects happen within the first month. And so CRS can manifest as like a fever, or you can, if it gets worse, you can get low blood pressure, and sometimes have to be admitted to the hospital. And for those, there's certain stages, and we give steroids and sometimes a drug called tocilizumab, and almost always we're able to reverse those side effects, but it's something we do educate and keep a close eye on. The second side effect, which is much less common with this, is called ICANS, and that's where you can have neurologic changes, difficulty with thinking, or decreased mentation, some weakness of the muscles. Again, this is very rare, but it's all about education and kind of watching for that and treating appropriately. And the third big one's infection. And so we do treat with prophylactic antibiotics to prevent infection, and sometimes we give a drug called IVIG to boost your immune system if needed. So there's a whole lot of education and prevention that goes into preventing and treating those side effects immediately, which really, I think, really mitigates some of those side effects. And so it's really amazing to have these drugs as options now for our patients.
And I have to add, instead of chemotherapy, which chemotherapy also has a lot of side effects,
Right.
including the cytopenias,
Yeah.
nausea, hair loss. So
Exactly.
so everything has side effects.
Everything does, right.
Now, I want to turn it to the Atrium side here. What is bispecific? Which ones are we using, and what kind of success rate have you seen?
Yeah, so we have all the bispecifics, which are approved, as well as bispecifics on clinical trials.
Right.
So we've been using mosunetuzumab for follicular lymphoma, glofitamab, and epcoritamab for
Right.
DLBCL. It's really for DLBCL, we usually do CAR-T as second line, and bispecifics have been shown to both the epcoritamab and the glofitamab studies showed that even if someone fails CAR-T cell therapy, they still have very good response. So these were phase 2 studies, and they remarkably had the same complete response rate. Epcoritamab showed about a 40% complete response rate, and glofitamab also had around 40% complete response rate. Epcoritamab is subcutaneous, glofitamab is IV. So and epcoritamab is given indefinite in terms of until progression, and or if someone has bad side effects and they stop, glofitamab, as Dr. Favaro mentioned, stops after 12 cycles.
Right.
So choosing those can be, I wouldn't say tricky. Both have very similar efficacy, but often you have to decide which one is going to work for somebody who lives far away, who wants very short because they get subcutaneous, versus a little longer but lesser number. So epcoritamab has many more, but glofitamab has less, but glofitamab is longer because it's IV, and epcoritamab is come in, get a shot, and leave. But important message, rather than focusing on the differences, is to say that the 40% complete response rate
Yes.
is really the most important thing to take home message. And many of these patients have already failed CAR T-cell therapy.
Right.
So, having that high-risk population in these studies who were refractory to previous treatments and yet did well. We don't have very long-term data, but glofitamab and epcoritamab, as more time goes, we are starting to see a flattening of the curve for some patients. There are patients who got a CR and they may still relapse, but there are some patients who will get into a more longer remission. We don't have 5-year data from either one of these two, so we'll know over time, how that looks. But it's remarkable progress.
Right.
Mosunetuzumab in general, has lesser CRS and or compared to glofitamab and epcoritamab, but is also used more commonly in follicular lymphoma. Again, all these are done outpatient. So we are commonly doing these. We have been involved in clinical trials combining mosunetuzumab with polatuzumab. Very effective strategy, not yet approved, but recent publication in Nature Medicine, and many other studies which are ongoing. The other thing we've done is we have combined these bispecific antibodies with frontline treatment. So we did a clinical trial of taking glofitamab with R-CHOP in the frontline, and we've seen remarkable, remission rates
With that 80%, 60?
higher. So,
Nice.
glofitamab, when you compare with R-CHOP in the frontline setting, has, in the CR rates in the 80%. So
Wow.
CR, not even overall response
Right.
rate. In DLBCL, we focus more on complete responses. Partial responses are
Yeah,
okay
they're
to
temporary.
mention, but they are very temporary.
Yeah.
So you really want to focus on complete responses. Sometimes a complete response may turn into a partial response may turn into a complete response, but
This is a great segue. First of all, for all the audience, at the end, we're going to test you on the spelling and the pronunciation of all these new drugs. There are so many new exciting therapies, and I know that our panel, the experts who have actually submitted some trials for bispecifics that they're particularly excited about, and we should have a slide coming up on that. And I was, if any of you guys remember the trials you would like to speak about, I would love for you to start. Dr. Ghosh, I think you already talked about one, and then we can move down if you guys would like to pick and talk to our audience about some of these new trials that are really revolutionizing treatment for lymphoma.
So I can talk about a few of these. So the EPCORE DLBCL-3 study is a study which is looking at patients who, in the frontline setting actually, who would be able to get either epcoritamab or epcoritamab plus lenalidomide if they are not eligible for anthracycline-based treatments. So, not every anthracycline being R-CHOP kind of treatments or even R-mini-CHOP, because, if the heart has to be in a good, without heart failure. So if somebody has congestive heart failure or some cardiac problems which will preclude them from getting, anthracycline-based chemotherapy, then, you could, instead of doing a R-mini-CHOP or R-CHOP, get onto this study. And the idea is to see if you move, as bispecifics are moving up from, more advanced relapse refractory treatments to earlier, what if we use them in frontline? Can we get chemo-free frontline treatments? So that is an effort with that EPCORE DLBCL-3 study, and also the NHL-5 study is looking in a more, epcoritamab plus lenalidomide in the relapsed refractory DLBCL. So after failing frontline therapy, and it has shown remarkable activity. It has not been directly compared with epcoritamab alone on a same study, but we have results from the epcoritamab alone, and that is 40% CR with epcoritamab plus lenalidomide. I believe the CR rate goes up to the 50s to around close to 60% range. So now you're seeing a two-drug combination. Lenalidomide, by the way, is an immunomodulatory drug. So you're combining an immunomodulatory drug with an antibody, which is also a kind of an immunotherapy. So you're trying to really focus on harnessing the immune system to fight against the lymphoma. And so, that is another powerful, combination. The glofitamab plus polatuzumab R-CHP, as Dr. Favaro mentioned, Pola R-CHP showed improvement over R-CHOP. That is sort of become a new standard. It showed improvement in progression-free survival compared to R-CHOP. So if that is the backbone, can we further improve on that? That's how over time, over decades, we have made improvements. CHOP came in the 70s, as Dr. Favaro mentioned. R-CHOP came 20 years ago, showed improvement over CHOP. Pola R-CHP showed improvement over R-CHOP, and now we are seeing if we can add bispecific antibody to Pola R-CHP, can it be even improved over Pola R-CHP? So glofitamab Pola R-CHP is a study which we have done at LCI as well, and also it's been done worldwide, and it has shown really, again, amazing effects. I just saw one of my patients very recently who was on the study, and he had extremely explosive DLBCL, about 2 years ago, and he's still in a remission. And so very effective treatment for high DLBCL. Glofitamab polatuzumab is another study which is ongoing. So taking polatuzumab, as Dr. Favaro mentioned, CD79B antibody drug conjugate, which is combined, if you combine with glofitamab, again showed very good, high complete response rates. Similar has been done for mosunetuzumab plus polatuzumab as well. So a lot of these combinations are being done. As you can see, the common theme is chemo-free. Now, I will say that some have chemo, CHP is chemo, and antibody drug conjugates are also chemo, but antibody drug conjugates are very targeted chemo, meaning only the cells where the antibody binds to, those spikes which Dr. Favaro has mentioned, when those drugs bind to when the antibody binds to that drug, chemo gets released in those cells. So there is much less collateral damage compared to if chemo gets everywhere. So, the focus is trying to do, as less in terms of lower the side effects, improve the efficacy, improve quality of life and quantity of life. So when you put that whole together, I think the field is moving very well towards immunotherapies. And I think these are all really good clinical trials which are out
It's
there.
very exciting. And
Yes.
for the audience, anthracycline is adriamycin, also known as the red devil. That's what people know it as patients, which can cause cardiotoxicity, and even in young people, we can end up with congestive heart failure at a young age, and it's sometimes very difficult to protect. Then some of the other medications used, Cytoxin, can actually cause neuropathy, which in some cases is irreversible. So to actually segue away from these medications is great for your, the quality of life, and have the same results or better. So very, very encouraging. So
comment on some of the other trials. These are all great trials. There's a lot of trials out there for diffuse large B-cell, and again, moving a little bit more away from chemo, more to these targeted therapies. There's another interesting trial where basically you're combining 4 different drugs, and none of them are really chemotherapy. There's an oral drug that's a BTK inhibitor. It's one of those proteins. It's an oral drug called Brukinsa. And that was combined with another monoclonal antibody called Monjuvi, plus Revlimid, plus Rituxan. It's 4 different drugs. 2 of them are targeted to the spikes, and one of them is targeted to a protein inside the cell. And then the Revlimid is there to stimulate the immune system, the T cells, to grow and attack the cancer. So you kind of start off as a newly diagnosed patient with these 4 treatments, no chemotherapy. And you're seeing a very nice response rate for those patients. And so in this particular trial, they started with this, and if they went into a complete response, then they got 2 cycles of chemotherapy, and then they went back on just the oral IV targeted therapy. So it's kind of a limited chemotherapy. Again, seeing a very nice response rate. So I think I like the idea of targeting some of these molecules on the outside or the inside, combining it with something that turns the immune system on as a way to kind of eliminate some of those long-term potential side effects from chemotherapy.
Right.
And I think that's kind of the theme that we're seeing here.
It's very exciting. So we're going to move on to the therapy, which is the most interesting to me because I had it, but actually I've had all of these. So I've had R-CHOP, I've had RICE, I've had intrathecal chemo, I've had a bone marrow transplant, and then while waiting for my T cells, I actually had a BTK inhibitor, ibrutinib, which also put in risk, and then I had CAR T. So hey, you know, it's like a buffet. Shows them all. So I'm one of the first patients to get CAR T cell therapy, and I'm going to have experts here explain that. But I sort of look at it as a patient advocate, I compare it to a Pac-Man. You put the T cells in, and the little Pac-Man go over and eat the cancer cells. It's a great visual. Or a heat-seeking missile. That's, you know, if you're into the more violent video games. But CAR T cell therapy is new. I personally received that in 2016 as a phase 2 trial. One of the earlier trials, I had Kymriah. There's actually other ones. It's been very successful for me. And I'm very, very grateful. After this, I went back to work as a physician. I have a great quality of life. Most of my side effects, which I have some, are from the chemotherapy, which did save my life, but wish I hadn't had those. And so I think that this is a great therapy, and now not only is CAR T cell therapy used for blood cancers, it's also being used in trials for solid tumors and actually autoimmune disease, such as lupus, actually scleroderma, and even some other odd things that was in the newspaper because they're using it for glioblastoma. But we're not going to talk about that, but I'm going to turn this over now to Justin, who's going to explain CAR T cell therapy better than the little Pac-Man.
I think that's a good analogy.
Yes.
Yeah, so I mean, the deal with your T cells, you talk about your T cells today. These are one part of your white blood cells that circulate around your body, and they're constantly looking to treat infection or try to treat cancer. And that's kind of part of their job. Why can't they kill cancer cells on their own? Because your cancer cells learn how to hide. There's certain proteins they can take away from their surface, so your normal T cells really can't find the cancer cells sometimes, and that's part of the reason why cancer cells can grow in your body. So the idea is how do we really stimulate those T cells and make them angrier and more attracted to kill and attack those cancer cells? And that's really what, in my mind, CAR T therapy is. And so the whole process starts by taking out your T cells. And so it's a process we get an IV and you remove part of your blood, and you're trying to isolate those cancer-killing T cells. And so we do that as a part of an apheresis process that happens in the clinic or in the hospital. And then those T cells are sent off to a company, and we talked about the 3 different products that we're looking at today. And these 3 different companies will take those T cells and they will do a few things in their lab. They will basically infect those T cells with a virus that inserts in that T cell a spike. We talked about many spikes. It's a spike that's basically an antibody that's going to attack CD19, or it's basically a spike of CD19 on the outside of that T cell. Okay, and then what happens is those T cells are now transformed. They will attach to a CD19 spike on a lymphoma cell now. They're activated, they're ready to go out and kill. And so they bring those T cells back. The whole process takes about 2 weeks. And then those T cells that are now changed and more active are reinfused back into your body. What they do is they have this new protein on the outside of their cell, and they can attack a CD19 spike on a lymphoma cell. So they go into your body now and really are homing in against the lymphoma cells. And once they get there, we know what happened with BiTE therapy. Once they get there, they're going to attack and kill those lymphoma cells. So that's basically how it works. It's pretty amazing technology. I think the upsides are now we have T cells that are active. Now we can see those T cells do their job. And the data we've shown with diffuse large B cell is that you can actually get 40% remission rate long term in patients that have had prior treatment, but now the lymphomas come back. And that's amazing. Those are amazing results. Robin is a testimony to that. But the downside is it takes a long time. So this is a process, and you have to wait. And there's also the whole issue of insurance authorization. And Medicare, pays for these treatments, but insurance companies really have to take a long time. And by the way, you're sick. You have lymphoma, and it's growing in your body, and we have to wait to get this whole process done. So it does require you to take other treatments, lymphodepleting chemotherapy, trying to control the lymphoma before we can actually get the CAR T cell done. process done, and it could take up to 6 weeks from the time you're met until we actually get the treatment into your body. Once you collect the cells, it takes about 2 weeks to get them back. So there's a lot of thought about how do we make this process better. The companies that make these products are telling us that 8 out of 10 patients that are eligible aren't getting the CAR T, maybe because they don't live close to a big academic hospital center, maybe because it just takes too long and their cancer's growing too quickly. And so a lot of the research, which we'll talk about, is really focused on making the process faster, or even can we create a CAR T on the, in the lab? We don't have to go through this whole process. We create it, it's ready for you. So that's what we're looking to talk about, I think, down the road.
So, Dr. Ghosh, you have actually spearheaded CAR T here in Charlotte, did the first cases and have a lot of experience. Love to have you talk about what we're doing in Atrium, but also really talk about the one thing that comes up on these support sides is the side effects from CAR T. Patients are terrified. We talked about it with Bispecifics, thank you, with the CRS and whether they get ICANS, and they're terrified. Meanwhile, they're not as terrified of a stem cell transplant, which actually has more side effects. So I'd love for you to comment, for everyone listening, about side effects, how you guys manage them, and what kind of results you've seen with CAR T at Atrium.
Yeah, so great question. So yes, we have had significant experience with CAR T at our center because we first participated in some of the clinical trials which led to the approval of CAR T. And, it's certainly a learning curve. Initially when CAR T came about, it was a learning curve to how to manage CRS and how to manage ICANS. So CRS can have grades, and grade 1 CRS can just be a fever. So when we think about CRS, people, the most important message I have is like yes, these are serious side effects, but most importantly, these side effects are reversible for the most part. You'll see some clinical trials report very high rates of CRS and some even with ICANS, which is, immune cell related neurotoxicity. So you can have confusion, word finding difficulties. Most of these happen, early on and within a few days of receiving CAR T. And they are, managed with a team of physicians and nurse practitioners and pharmacists and nurses who are very, very, in tune with how to manage these side effects. We also have help from, ICU doctors is needed, as well as neurologists and infectious disease specialists. So it's really a team approach. And, each grade of CRS has its own treatment. So as the grade of CRS goes higher, or even ICANS, as it goes higher, then the treatments can, intensify more. But I can tell you that like the mortality from CRS and ICANS is extremely low. The reversibility is extremely high. CAR T has 40% long-term remission rate. So, and more importantly, it's a one-time treatment. So you come in, you get the lymphodepleting chemotherapy, 3 days of outpatient chemo, followed by a couple days rest, then getting the cells, then a week of monitoring for CRS or neurologic side effects. If none happen, then, outpatient. And if they happen, then treat them, reverse them, and then after that, monitor for infection risk. So the treatments for CRS can go from just Tylenol to, adding tocilizumab, fluids. Sometimes patients need oxygen. Sometimes patients need multiple doses of tocilizumab, and sometimes introduction of steroids and other drugs like anakinra for ICANS especially. So, but what we have seen is by doing these measures and, and being aggressive in terms of treatment, these are reversible. The goal has also been to see if we can lower the intensity of CRS and the incidence, and sometimes, and also neurologic toxicities. And there are drugs which can be used, for example, prophylactic steroids can sometimes lower the intensity of CRS, and that has already been approved. So there are just multiple ways, but if you have a team who has been doing it for a while and really can react, whether it's at midnight or 2 o'clock in the morning on a Saturday, it doesn't matter. We have 24/7 coverage in the hospital with hematologists and dedicated nurses who know how to manage this. So then, it becomes, there's another side effect which is not very common, but is very important to address if it happens, and that's called macrophage activation syndrome, or HLH. Again, that is also managed with many medications, and we are able to recognize it early by monitoring things like ferritin and other markers as well. So, I feel that, the CAR T often is perhaps underutilized because of the fear of side effects, but the potency which it has, I think far outweighs the risks which are associated with it, especially now that it's been so long that we've been able to manage that risk in a relatively, protocolized manner.
So my therapy was pretty much outpatient. So that's why I think that some of the things are actually drifting toward outpatient until you actually need to be inpatient, which I think decreases your risk of infection and also increases your quality of life, and probably decreases your chance of having ICANS in some ways, just because you're in your home and familiar surroundings. So my understanding is a lot of hospitals are trying to move to that, but it just depends on the type of CAR T and also the patient.
And the patient and caregivers. So
Exactly.
I think another very important thing for CAR T is you do need to have a caregiver, because if someone is having confusion, you do need the caregiver to find, and if you're outpatient, to be able to call and say that, okay, there's something. If even in outpatient setting, then for the initial part, it's very, very frequent follow-ups, almost daily. And then after that, so sometimes distance from the center is an issue. So if someone lives very close, you can do it outpatient. If someone lives far, it may be hard to come back and forth. Then, so there are ways to work around it, but as Dr. Favaro mentioned, we are working very hard to try to overcome barriers to CAR T. I think that is the most of it. So one of the ideas for this forum is to overcome the patient barrier or the physician barrier. And, that's by education. Be aware of side effects. Don't be freaked out by side effects. If CAR T is right for you, go for CAR T at a place where they know how to manage these side effects and, get the benefit as needed.
So moving on to talk a little bit about trials for CAR T. First of all, I want to talk about trials in general. LLS is sponsoring this. They have a patient advocate, nurse advocate that can actually help patients look for trials, because it can be overwhelming. The first person to ask about trials would be, of course, your physician. But no matter how good the physician is, they can't know about all the trials in the United States or the world. The second, obviously, LLS is great, and there is a site, www.clinicaltrials.gov, which is what I actually utilized when we were looking for a trial. It's a little bit harder to navigate, but not that hard. So for our audience here and online, trials are accessible. You can do this. You do have to be your own advocate to some situation. So I want to throw this out to the CAR T trials.
And I'll just say one thing, the trials, for anyone who has barriers to clinical trials, remember, we would not be here today if it was not for clinical trials. Even CHOP came through clinical trial, which was started in early 70s. Our CHOP came through clinical trial, CAR T, everything. Otherwise, we would be
And again, I'm an example. I was one of the first. I was a clinical trial, but I've actually told other patients that sometimes the best treatment you can receive is through a clinical trial. And, this is not something where you're a guinea pig. No, you're actually getting the best.
Cancer clinical trials don't really often take a cancer drug and give a placebo. They usually have a really well-established cancer regimen, and they may add one drug to it. But those who are not getting the drug at least get the best established cancer regimen. So important. Unlike many other diseases where it's a placebo versus this, but this is serious, life-threatening disease. So there's no study which will say, oh yeah, we'll give you sugar pill and we'll give you, otherwise you'll get the real treatment. Even if you're getting sugar pill, at the background, you're getting the standard of care for the most part. So at the least you would get the standard, and then you would get the other drug, the new promising drug, And then if it's a phase 2 study or a phase 1 study, that's basically just everybody gets the same treatment typically.
Yeah. So excellent.
A
So,
lot of our trials are patients that have been through all these standard treatments and they may have had CAR T, they may have had BiTE therapy. Lymphoma comes back, and
Yeah.
what do you do? And that's where really these companies are really on the cutting edge of developing some newer treatments. You know, CAR T therapy that's off the shelf, for example. We'll talk about that, but I mean that's where you're really kind of seeing if we can kind of really get something that's really much more accessible and quicker to use.
yeah, and there's a few trials. I know that on my side, I know some people are in the Transcend trial for follicular lymphoma. That's there's a lot of people enrolled in that. It looks like it's very successful from what I've seen from the data from ASCO.
Yeah.
Anybody have any comments on those?
Yeah, so Transcend follicular lymphoma took patients with relapsed follicular lymphoma with and treated them with lysocell. And you know, it's been reported, and it has really fantastic efficacy with very high response rates in the 90s.
Yeah.
And like high complete response rates. The follow-up is not very long, so that's the one downside. But the FDA is doing a priority review to see that, like, if this would is good enough that it should get approval in follicular lymphoma. It also has been done like in second-line patients, so they've just failed frontline therapy, and second line has very, very good activity in the second-line setting. The S2114 study is a trial. Remember, we said that 40% patients with large cell lymphoma will get long-term remission after CAR T. So what about the other 60%, right? So I think we always have to think about the people who didn't benefit. We have a great example of benefit right here, Robin, but there are others who didn't, right? So when I said that complete remission is really the most important thing for diffuse large cell lymphoma, what about people who get partial remission or stable disease? And I say, okay, it didn't grow at least, but that's not good enough, because within a few months, many of those patients will progress. So what if you can intervene before that with these bispecific antibodies and polatuzumab, which we've talked about. So this is a trial which is trying to improve the outcome of patients who are in a partial remission or in a stable disease by adding drugs to post-CAR T, and then trying to see if they would benefit and convert them into a complete remission. So this is a trial nationally, is there. We have it open at our site as well. And then this ELARA study is the same product which Kymriah, which you received for DLBCL, but this has also very good activity in follicular lymphoma. So, you know, again, showing high response rates, low CRS, low neurotoxicity, durable remissions, now with 3-year follow-up, which has been presented recently, and showing that nearly close to, I think, 60% of patients are in remission, even at 3 years. Remember, one-time treatment given 3 years ago, and patients are in remission. And many of those patients were in that POD24 group, where they had progressed within 24 months. So their first remission was 2 years, and now the second remission has been lasting for 3 plus, and I hope 5, 7, 10, 15, but time will tell. But you know, that's where the whether it's curable or not will come in.
Follicular, yeah.
For follicular, but ELARA is a study for tisagenlecleucel, or Kymriah, easier to say Kymriah.
Yeah, as I said, there's going to be a test for everybody. Spelling,
yeah.
pronunciation.
So yeah, so that's another
encouraging.
Yeah, it is exciting to see the CAR T therapy patients in follicular. That's a disease that tends to relapse over and over.
Right.
And seeing long-term responses, like you said, with that drug. I mean,
Right.
And people can go on with their life.
Right.
And
The other
totally
trials
changes
I
things.
do like are looking at CAR T patients that don't have a complete response to CAR therapy. Let's go ahead and bring in the BiTE therapy
BiTE, yeah.
to those patients as well to try to get them into that complete response.
Right.
You know, we're part of a national network of cancer clinics called OneOncology, and we're looking at, some of our clinic sites are looking at doing outpatient CAR T therapy. And the different products that are now approved, Lysocell, or Breyanzi is the brand name. That is the one that really has the least of these side effects and is most predictable. And so what's happening in outpatient clinics in places like Nashville, Tennessee, and OneOncology Network, we're actually doing the pheresis and giving the patients back their CAR T therapies and then watching them as an outpatient. And they can be actually watched for 4 days. It's actually pretty predictable that at day 4, that's when a lot of the side effects happen for that particular product. That has the one that has the least side effects. So that's one example how we're kind of moving things more towards the outpatient. It's kind of watching people at home. All right, it's day 4, you're starting to have side effects. We're going to probably bring you in now and keep an eye on you for a few days, but then take care of your side effects and go home. So I think that is exciting to see things move more in the outpatient setting. The other thing is looking at it as a company called Fate, for example. There's a lot of companies like this that are developing new CAR T therapies. And why do we need to take the T cells from the patient and then and engineer them and put them back? What about just taking regular cells we can have in our lab? You can take a culture of human cells, and believe it or not, you can take cells that are stem cells and actually make them turn into T cells in the lab. And a lot of companies are doing that, where they're actually developing CAR T cells in the lab that are engineered, okay, so they can go in and attack the lymphoma cells. But they're also engineered so that the body's immune system won't attack them and kill them, because these are foreign cells to the body. And so one of the other trials that's happening in the One Oncology Network is working with Fate to kind of use what's called allogeneic CAR T cells. And allogeneic means it comes from a different person. It's not your own cells, but they're engineered in a way to help your body to accept them and to see if you can get a response. And multiple companies like that doing this. And in some cases, these are patients that have been through BiTE therapy, CAR T therapy. They've been through everything. And you can actually get a response and a reduction in their lymphoma by using these foreign stem cells that were created in a lab. I think that's really where, to me, the future is looking at this in the outpatient and having it ready for the person when they need it.
And it's also less cost, because it's technically off the shelf, so it's prepared, which would be excellent. So I know at some of the meetings, people still have talked bispecifics versus CAR T, which order? I know talked a little bit about bispecifics after CAR T. Some people are saying maybe you should do it before CAR T. Any comments?
So there was a recent study from Europe which was presented, most of just the way it came, CAR T came first, bispecifics came later, outside of blinatumomab, which was for ALL, but for most of our DLBCL and follicular, bispecifics came later. So naturally, by the time bispecifics were available on trials, CAR T had already been there. And so many of the patients who got treated with bispecifics, we know that after CAR T, bispecifics are very active. But what we didn't know is the reverse. So recently, there was a European study which was presented and showed that if you use bispecifics before CAR T, you can still get really good activity from CAR T. On that study, a lot of patients had failed bispecifics, and then they went on to get CAR T cell therapy, and CAR T cell therapy was effective. Now, in the United States, CAR T bispecifics are not approved in the second-line setting, versus CAR T is approved in the second-line setting. So naturally, getting CAR T before bispecifics makes a lot of sense. But if somebody were to get the reverse, at least we know, we don't have long-term data from those bispecifics in second line, but we do have data saying that if it didn't work, at least CAR T may be able to rescue those patients. So I think that was a very, very good study. Overall, we do great in oncology in terms of getting new drugs approved, but we don't do a great job in sequencing them. And that's left a lot to the physician and also in discussion with the patient, because not everything from the menu is going to be available or accessible right away. So, CAR T, aggressive disease, you may have to do something right away because you can't wait for a few weeks, 6 weeks or so. Bispecifics, if CAR T is available and going, then you maybe want to wait and do the bispecific later. So at least in DLBCL, I think right now I would do frontline treatment, CAR T and bispecific. In follicular lymphoma, you could do, the reverse sequence. It's a more indolent disease. We don't know about curability as much. And we know that, mosunetuzumab does work really well in follicular lymphoma in the relapsed refractory setting. You have long-term remissions, and you could save, axi-cel or, tisa-cel, and if liso-cel does get approved, then liso-cel for later. But just to say that, now as we are seeing more longer data with those things, you have to think, do you want to be on a treatment where you are coming in frequently, versus getting
Just a one-time deal.
one-time treatment. But obviously, the treatment where you're coming in frequently has lesser side effects than the one-time treatment. So, it's a discussion. Clinical trials, will they ever be done to answer the sequencing question? I don't know. I think we'll learn over time. What will matter is the side effects and the durability of the response. Any response which is durable, will be higher in the flow chart compared to the ones where relapse will happen sooner.
So, in general, it just depends.
It depends.
And I've been in medicine for a long time. When I trained in medicine, oncology was still relatively barbaric. I would say, chemotherapy and cancer treatments involves cutting, burning, poisoning. That's how we've treated cancer forever. Way back in the 80s, they didn't even have antiemetics or ports, so giving people adriamycin was difficult, to say the least. And we've progressed dramatically. All these side effects, all the oncology teams, they found ways to decrease the nausea or even take care of neuropathy, all these things, but the side effects are still there. So we've already discussed this a little bit, and I'm throwing it out to the team. Do you see chemo-free treatment of cancer in the future, in the next 10, 15 years?
Yeah, I think that's the direction we're slowly heading in. I think a lot of these trials that we see, that we've talked about today, we're slowly moving things that were thought to be more exciting and more novel approaches from your fourth, third, second, and then slowly come into the frontline setting. And I think that happens over time because the more we learn, the more experience we have with all of these, wonderful patients who've been on trials, who've given us this knowledge. I think we're headed in that direction. And I think as a community oncologist, that's extremely exciting because, I see patients. And I hope to see patients for years to come who are going to be disease-free, who I'll just be monitoring. And folks who've gotten things like chemotherapy up front, they're often left with life-limiting or, daily activity-limiting side effects like neuropathy that affects their daily life. So it's extremely exciting to have this option of chemo-free, which without long-lasting side effects, and people are going to live longer with these, disease-free intervals. And so it's very exciting, and I think that's where we're hopefully headed.
Justin, I know.
Yeah, no, I think it's a combination of things. If you look at chemotherapy, these are chemicals that kill fast-growing cells, and that's pretty good against lymphoma because these often are fast-growing, and especially our diffuse large B-cell lymphoma. So there's been very active treatments that have put people into long-term remission. But the downside of chemotherapy are the potential long-term side effects and making it hard, and it's harder to go through. So what can we do? Well, cancer cells are complicated. We've got the DNA inside the cell, which has 30,000 genes and over 100 probably mutations or changes in those genes. You got all these crazy proteins in the cell. A lot of them are active and helping the cell grow. And there's a lot of them, and all these different spikes on the outside of the cell. And so you really have to think about how you attack not just one protein or one spike, but multiple. And that's where that trial that I was mentioning earlier, took a BTK inhibitor and attacked the protein inside, and had a couple of drugs attacking the spikes on the outside. I think that's probably where we're going to head, is trying to avoid the ones that are so toxic with the chemo, but multiple targeted agents, I think, is probably the way to go. And I think that, if you just do one, for example, let's talk about bite therapy and what happens with those patients. It's very effective. It's pretty early. And so what's going to happen down the road? Will patients eventually, will there be a potential risk of the cancer coming back even with bite therapy? And maybe the T cells get tired, something called T cell exhaustion. So you're taking the T cell and bringing it to the cancer cell and then turning that T cell on, and it kills the cancer cell. But over time, those T cells get tired and they don't want to work as well. And so, sometimes it's as simple as giving people a break off treatment to let their T cells recover. But the other thing I think that we're going to head towards down the road is really limited duration of therapy, but baking something in. So you give the bite therapy, but we know you can exhaust your T cells. We need to add in another targeted therapy to kill some of those proteins, and maybe 2 or 3 of those for a limited duration. I hope that's where we end up to finally, wipe it out for good. Yeah.
Well, it's very exciting. I love listening to all of you guys. This is a great team. We have more of a tertiary care. We have people in community centers. And one of the things that all of us as doctors are focused on is access to care. How do we improve access to care? If you are in rural North Carolina, how do you get access to CAR T. How do you get here? How do you coordinate this? You're in Rock Hill. How do you get there? So I want to talk first. I want to talk, Non-Hodgkin, what do you guys do in the academic centers to reach out to community doctors? And I would love for you two to comment on how you communicate. And one thing in my case, there was no CAR T offered in any of the Carolinas or Georgia or Virginia or anywhere outside of when I had it. So I actually went to Ohio. So my oncologist here had to coordinate with an oncologist who was in a trial in Ohio. That's difficult. So please comment on how you do this. And I would say that the team in Charlotte did a fantastic job for me.
Yeah, no, so I think, that's the most important question. I think it was a bold step for us to say that when CAR T was not yet available commercially, to, say that, okay, we are, established transplant program, so let's just go in for CAR T trials. But it was still late for you.
Yeah.
So we signed up in
2 years later.
2017, late 2017
Yeah.
is when we moved forward with signing up, for the Transcend study, which eventually led to approval. But access, therefore, and once we signed up for the study, we were the only center in all of North and South Carolina to offer CAR T, CD19 CAR T,
Right.
before any other center. And we got patients from everywhere, from West Virginia,
Right.
North, South Carolina, everywhere on that study. So I think the access is certainly a very, very big issue. For CAR T, it becomes even bigger because, you do need caregiver. So, how do we overcome some of the socioeconomic barriers where, the caregiver would have to take some time off, and be with someone else in a place which, typically we would need patients to be at least within a 1 hour radius. So then they would have local housing, which is doable. But then being there and, having that access. So the first part of access is provider education. So physicians education and understanding the benefits of CAR T and referring the patients in a timely manner, because as Dr. Favaro mentioned, could be up to 6 to 8 weeks sometimes to get CAR T. So if you wait for the referral, then it may be not doable because the disease will take off. So early referral is extremely essential for CAR T. I think patient navigation can be very, very helpful, to help find resources so that, whether it's local housing, whether it's any other type of support, I think that's an essential. Insurance can be a barrier, especially in terms of single case agreements. And that can be a huge barrier, but we are trying very hard. We have actually a study which we are looking at, the effect of these insurance problems on outcomes. So, that is a barrier which we'd like to overcome. I can tell you that, those are all barriers which some of it are within our control, some of it are not within our control. There are ways to control the disease. So giving the right treatments, very important. For example, we've learned now that if you give bendamustine, then that can really mess up your CAR T. Bendamustine kills T cells. So if you kill T cells before you collect T cells, then those T cells are not going to work. Either you won't have much, or if you have, they may not be as functional and they may not really be able to do the job. So, which is the right treatment to use if you're planning CAR T? So that is, there's so many available. Do you want to use modify your regimen somewhere so that you can control the disease, but perhaps not kill all your T cells before you collect? Or do you want to wait? But if you wait, then the disease may take off and that may not work. So there's a lot of fine tuning involved, and the team would decide what's the best interest in the patient, for the patient. And then, try to do this in a really timely manner. We coordinate very well with all our regional sites within Atrium LCI as well as, beyond, as, talking to Dr. Favaro's practice and several other practices. I think the bigger challenge is those who live far away. Do they want to come to Charlotte to get it? Or, say that no, they would not be able to do it because it's just not feasible to come here. So I think, those are really, and that's where eventually having outpatient CAR Ts done locally, those kind of things, and also having the expertise to manage the side effects and to partner really well, that if side effects happen, what are we going to do? Right? Are we able to take care of the person who actually has grade 4 ICANS or grade 3, 4 CRS, and manage them, because we have such good tools to manage these. We also don't want to have the treatments in an environment where there isn't the expertise to manage this, because then it becomes very hard. And somebody came in for a potential curative disorder, and they perhaps were going to be cured, but they succumbed to the side effect because the team was not able to manage or didn't have the expertise to manage it. So that would not be the right thing either. So I think the side effects are coming down, but being prepared to be able to manage and step it up, and have that expertise to manage complex side effects and then turn things around is really the right environment to get it. And we have more CAR T centers today than what we had 2 years ago. And I hope it just keeps getting better and better, so that more patients all across are able to access this treatment. And get it. And then the other part of it is coming up with protocols where the side effects become much lower, but you're not compromising efficacy. So I think that's the other part of it. So the advancement with clinical trials and some of the products which now have less CRS, less ICANS, but not zero. Unfortunately, I don't think we're going to get there.
Zero is possible. Yeah.
So I think that's
But before and after, if somebody comes, or like some of you guys, your patients, what about if there are trials at Memorial Sloan Kettering or MD Anderson? So what kind of communication? So the idea was that people can get follow-up with their local oncologist.
After it's a one-time treatment, right?
So you guys communicate with the community hospital doctors, and that's what happened in my case. I know you do a lot of trials, and I know some can't be here, maybe. So then sometimes you have to go somewhere else for, for a treatment or for some kind of trial, and then do follow-up blood work, follow-up everything, scans here to make it more convenient for the patient.
I think the most important thing for CAR T is that there are 2 side effects which can persist after being discharged. Commonly it's done in the inpatient setting. We are moving towards outpatient, even at Atrium as well. There are 2 things which to look for. One is low blood counts.
Yes.
So low blood counts is an important one, and that can persist for a little bit of time. And for the most part, that's because of the CAR T and the lymphodepleting chemotherapy which was given for that. But sometimes, if patients have had many prior treatments before that, low blood counts can also be because now they've developed MDS or a pre-leukemia situation. So again, paying attention to the low blood counts and saying, okay, this is getting better, we don't need to do a bone marrow biopsy, versus it's persisting for a very long time, then I think looking in the bone marrow to see if they have developed something else, there's some other reason for the low blood counts other than CAR T. Second is infection risk. CAR T takes out the B cells because normal B cells also express CD19. So, with CAR T, the B cells can really go down, so immunoglobulin levels go down, and then so you can check the immunoglobulin levels and give IVIG. But vaccine responses also go down. So if someone had a vaccine to flu or COVID, they may not be able to respond really well. So the people are prone to infections. So really, I think patient education is very important. As to letting us know that I always counsel our patients that if you have a cold or something like that, reach out to us first, because many times we would react on it faster. We won't just give a Z-Pack for a cold. We would assume that a lot of it is probably, we'll get them in, get a swab, check with viruses there, check the immunoglobulin level, give them antivirals if antivirals are available, give them IVIG if the IgG is low, and really help them overcome that infection. Get some imaging needed to see if there's pneumonia. All those things, rather than sitting on it, because when the immune system is low and you get a virus and you sit on it for some time taking an antibacterial, which is not going to work because it's not a bacterial infection, but it's a common thing to just give Z-Pack or amoxicillin for a cold, but it can actually get worse. So I think, educating our patients that, there are infections can be there, but we know how to manage them. And please, communicate quick. And then if they're going back to their practice, then communicate that to the practice as well as the patient so that they can be managed appropriately compared to, some other person who is not as immunocompromised.
Excellent. So I think this has been a great discussion. At some point here, we're going to move into questions from our audience here and remotely. But I would like to turn that back to the team to say if there's something else you would like to tell the people in the video about diffuse large B-cell and follicular and treatments and the future. Any final statements, Justin?
Yeah, I think that this is so much education for patients and doctors. These new treatments come out, and it's our job to learn about them. And you can think about CHOP. When CHOP came out in 1976, it was our job to learn how to give it and also how to manage any side effects that come up. And that's the very same with CAR T therapy. And we are constantly educating and learning about these new treatments. And quite frankly, 4,000 papers come out every day in healthcare. There's a ton of information coming out, and so we are really learning about them. I think that the cooperation that we have as a community practice with academic centers is very important. So when we see patients that need CAR T therapy, we refer them to you guys, and then we take them back and help to manage all their potential side effects. The technology that's advancing to make these treatments less toxic, I think, is key. We used to have to admit patients overnight for EPKINLY, for BITE therapy. Now we can do it all as an outpatient. That's the type of thing that's happening on a daily basis. And the only other thing I was going to mention is that, I think that, physicians will never go away. We are here because we know you. We take care of you as a person. But we are going to see more and more about artificial intelligence coming into healthcare. And I think I mentioned about so much information coming out every day. It's happening. And so I think we do need to kind of look at that and embrace that. One example is that, somebody comes in and they have lymphoma. They need treatment. What should their treatment be? There's so many different factors, what their age is, what their own personal health, what their disease is, what potential treatments there are, what side effects there can be. And it really takes a good physician to understand the data. But over time, I think we're going to develop, there probably will be the development of assistance to doctors with artificial intelligence and neural networks that I think will help. And there's journals about AI and oncology. And I think this is going to be, the future for healthcare as well.
I think I'd like to end by saying, none of us in medicine work in a vacuum. I think it's a concerted effort getting these patients to the most advanced treatments out there. And I think in the community, our responsibility is, one, to know that these even exist, and also to maintain that chain of communication with academic centers to get our patients to the care that they need, but always serve as home base. And so, give patients that feeling that, yes, we're sending you away, but you're always going to come back, and we are here to take care of you. And I think it's always been a great collaboration between community and academics, but getting that relationship established and always having that chain of communication to ask questions, get opinions, and it doesn't always have to be advanced therapy. Sometimes you get a challenging case that you want to discuss with someone who's seen something like this before. So I think it's important to have that relationship with academics, but also know that they're going to come back to you, and you're going to be taking care of them for years to come. So I think that's also a privilege that we're really excited about. But no, I agree. I think it's very exciting to see what's on the horizon. It's exciting to see what we can do for our patients, and it's a learning process every day. We learn something new.
Yeah, so I really cherish the community academic partnership. I've cherished that over the years. That really helps patients to get their treatment locally being followed, but also get access to a specialist who just treats that disease. And perhaps even when I started, about 14 years ago, lymphoma treatments were not as effective, but were simple. You get this is one option, then your second line is this, and then after that, there's just one or two options, and that's it. But now, there is just a lot of options. So when you have so many options, each with their unique side effects, and sequencing is not worked out, then how do you know which is best for you? And there's so many intricacies. If you use this, then the next treatment could be a problem. So just trying to understand all those intricacies and trying to make that choice. We didn't even talk about some of the other regimens like tafasitamab plus lenalidomide is available, loncastuximab is available, 2 bispecific antibodies, 3 CAR-T products, R-GemOx, which is a chemotherapy. There's just so many options. And not that, I don't think anybody has a crystal ball to know which option is going to really work out and give somebody treatment free for good. But, trying to put that whole thing together and trying to find the right option which would work best, and also be in touch with what comes out tomorrow and day after and still keep, with the pace at which this is moving along, it can be challenging. So I think that's where, the academic community collaboration can be very good, and, patients can always go back to the community to get their treatments and, still have access to a new clinical trial or some latest treatment which is out there, and have really good care. So, I think, that's sort of the main thing, and I would also encourage participation in clinical trials, knowing that these are ethical and, they are vetted by institutional review boards. So, that is how we have come to where we are, and I hope that we get into more chemo-free. Some chemo is still very effective, and, I would not say anthracyclines have saved many lives. And so therefore they've been there for 50 years. But I think if we can achieve our goal with less toxicity and harness immune system, that would be fantastic.
So great summary. For me, I'm just honored to be here. I have to put a shout out to the patient story. Unique ability for patients to get their voice out, for people to do research online, and segue to that as a physician and a former patient. It's very important to be your own advocate, to research things, to ask questions, and to keep your mind open. Sometimes clinical trials are the best treatment. It may not be the treatment for you, but do consider them. And also consult with your doctor. It is okay to get a second opinion at some points, but medicine has come a long way, particularly because I'm a little older than these folks. When I first started, there was really not much available. And the survival rate, for example, for non-Hodgkin's lymphoma was about 40% when I started, if maybe 30 or 40. Hodgkin's was higher. But the other message I have to everyone listening is I hope that everyone gets a treatment and they'll be in remission like myself. And at that point, I really think you need to live your life. You need to enjoy your family, you need to travel, work, stay healthy, exercise, enjoy your life. Don't let cancer define you. It's part of you, but there's much more to you. So enjoy life. So that is one of my messages. And now we're going to move on to our first question. We have a question. Joan, what is the polite way to get a second opinion without being rude? So
that's a good question.
That is a good question. How about, why don't you take that one?
Of course. And like I alluded to earlier, I don't think any of us work in a vacuum in medicine, and there's very rarely are there egos in medicine. So I think I think as a physician, you try to make the best choice for your patient, make the best decision for your patient, knowing that there may be something out there that is newer, there may be something out there that may be better for the patient, and if everyone is entitled to a second opinion, in my opinion, and I think that's just how we learn more. And if somebody comes back to me with a different treatment approach and says, hey, somebody else recommended this, that's something I would definitely encourage. You need to, like
Right.
you said, you need to be your own advocate. And if you feel like this is not something that's working for you, that's been recommended, you have all the right to get a second opinion. So I don't think you're being rude at all if you're getting a second opinion. I think you're entitled to that right, and it's actually encouraged if that's what you feel is right for you.
So, excellent. I would agree, even as a radiology situation, we get asked for second opinions all the time. We are human beings, doctors are humans, we are not perfect. We also can look at the same case and sort of have a different opinion. So we're not insulted. That's just not the way we've been trained. Matter of fact, it's the opposite. We've all been trained to work together, and I would say that happens 99% of the time. There's always exceptions. So anyway, what's the second question? Do we have that? So I'm on the Epkinly regimen. We considered CAR T, but wouldn't be able to provide the 24/7 care required. So far, it is working very well. How does it stack up with the results compared to CAR T? And Lanjan, you sort of were on that, so you can answer that.
Yeah, so, this is a really good question. So, they have never been compared head to head. So there is currently no clinical trial which takes half the patients, then give them Epkinly, and half the patients get CAR T. That would be the best way. We can compare two groups of patients is if they were randomized on a clinical trial, they had similar characteristics in both groups, and then you follow them over time and find out, what was the effectiveness of one versus the other. If not, then you're comparing across trials. And when you compare across trials, it's flawed because the patients who went for Epkinly may have very different characteristics than the patients who went for CAR T. Right? And in fact, many patients who went for Epkinly on a clinical trial had already had CAR T. So how could you compare the effect of CAR T with a drug which is used for post-CAR T failures? Having said that, we are left with no choice but to compare across trials. So I will say that the CAR T complete response rates, if you look at, the commonly used CAR Ts, the complete response rates for CAR Ts is much higher than the complete response rate for Epkinly. Epkinly is around 40%, CAR T complete response rates are usually higher, 50s, 60s. That being said, it comes down to that 40% number, because if people, even if they get a high complete responses, some people will start relapsing despite getting a complete response. And long term, we know that CAR T will give about 35 to 40% people will have long-term remission. We don't have that long-term yet with Epkinly because the complete response rate is 40%. Of course, many of those 40% who get a complete response will still progress over time. Not many, but some. So it will drop beyond. We know the upper is 40. We don't know the long-term, how many, whether it will go down to 30%, 25% as we go up to 5 years. We don't know that yet, but we will find out over time. At this point in time, at least for DLBCL, we feel that, perhaps CAR T is better, but if CAR T is not feasible for you, for example, for the person who asked, Bispecific would be the next best option, and all you know that you would be in that group of people who will get that long-term complete remission. Important thing is, are you getting that complete remission or not? And, if it's the complete remission, and then, that's where we see the sustainability in terms of long-term. If it's not a complete remission, then, we start seeing early progression. So I think very good option if CAR T is not feasible.
And I think the other thing just to make on that point is that, like you said, Nilanjan, a lot of patients that were on the Epkinly trial had CAR T therapy before. And so, but if you have somebody who's never had CAR T before and you have this option of CAR T or BiTE therapy, which one do you choose? Or you may be eligible for both. I think it comes down to logistics. It comes down to what's going to be a good fit for you. And keep in mind, too, that if you need CAR T therapy later, you can still get it, because the studies that this most recent ASH showed that even if you had BiTE therapy before, you're still eligible to get CAR T therapy later, where the Epkinly is hitting CD20, the CAR T is hitting CD19, so you really, there's still two very different ways of attacking the lymphoma. So I think it's still a great option for those that, choose Epkinly for whatever reason. I think this is still an option. You can sequence things and still have a great outcome. You don't have to do, and it doesn't necessarily matter how you sequence it.
And one other thing is, if for some reason this doesn't work and you go to CAR T, a lot of the hospital's social work has come a long way with actually helping people get 24/7 care, with with assistance to get a nurse coming in, or you actually go into a rehab center for the 4 weeks. So there are options, and hopefully you won't need them, Don, but since the Epkinly is working well, but just realize that there are things that the hospitals are now aware of, and they're trying to assist patients with that.
There's also many devices coming out for 24/7 monitoring.
Yeah.
Especially in the outpatient setting, there are many companies which are coming up with these devices which will monitor your oxygen level, your pulse, your heart rate, your temperature, and then sort of feed them back to the electronic medical record and create alerts. So, at least from a vital sign monitoring, so people are trying to overcome this barrier, understanding that 24/7 support, even if it is for a short time, is a lot on a caregiver, especially if the caregiver has to work. So, and the other thing is that sometimes you can also rotate caregivers. You can have,
shifts.
you don't need to have one caregiver. Most places will allow that if you have multiple caregivers, one person chips in for a week, another person chips in for a few more. So, I think that's doable. But I think, as Justin mentioned, Epkinly is a really good option if you were not able to do CAR T, and still you can have very long remission, and perhaps, I hope for you, not even needing any further treatment ever again. That's always the hope. That whatever treatment you're getting, hopefully that works out for you and you don't need anything else. But if you do, then there are certainly options available. And all there'll be even better treatments in a few years. Maybe allocars will really hit a big way from the many things which are coming or not. We don't know yet, but we'll find out.
Yeah, that's the advantage of the BiTE therapy up front, is that you can actually, again, if you need something later, it may be a lot easier, with a lot fewer side effects, and it can be done as an outpatient. And so we talked about how Epkinly now you can give steroids and reduce, and really don't need to be in the hospital for that drug. But as we make more progress on CAR T, we can maybe do that as an outpatient too, reduce those really severe side effects. So I think sometimes there's an advantage to waiting as the technology advances.
But in general, I would still say that if it is accessible, knowing the track record with CAR T and knowing that now we have 5-year data, we certainly have a cure rate with this, we still like to sequence CAR T before bispecific, just the way where things are. But over time, we'll find out if things change and, do it the reverse order.
Okay. Next question. Do we have any others? What is the median length of remission after the first BNR treatment?
For which disease?
I don't know which.
Follicular lymphoma.
I guess I would assume it's follicular.
Follicular lymphoma.
But we don't know what stage. So Diana, it's hard to tell when you don't know what stage you are, but.
Right. I mean, generally, we talked about this, that, you have, even if it's for follicular, let's
just assume it's follicular stage 2 or something.
Right. And so if it's follicular stage 2 or something like that, generally you do have a sustained response after BNR treatment. And we're looking around about 5 years or so. So, I mean, I guess we need more information to answer that question appropriately, but that's
around 5 years.
Approximately,
It may also sometimes depend on whether rituximab maintenance was used or not. Could be a little bit different
a little bit longer.
with maintenance versus without maintenance.
But it's usually quite good.
It is, yes.
And,
for follicular.
so
I've even seen patients who are 10 years out after bendamustine rituximab and have not relapsed. And some people will relapse early. So it's a whole spectrum.
Okay, next question. If you have follicular lymphoma that transforms into diffuse large B cell, it went into remission. It went into remission after treatment. But a few years later, the follicular lymphoma comes back. So follicular transformed to diffuse large B cell, it was treated, and now the follicular has come back. What is the probability that this will transform again?
So with follicular lymphoma indolent, there's a small percentage of transforming every year. So as more years go by, that risk accumulates. If it's already happened, so if, will a second transformation process happen? Of course, it's possible, but the likelihood goes down because it's a random event. And, but, what are or is it a relapse of the previous transformed follicular lymphoma? That's hard to sort out. But usually what happens with the transformed disease, if the transformed disease has been in remission for a long time, that's an aggressive lymphoma. And usually aggressive lymphomas respond well to whatever the treatments were given to them, if especially a long-term remission was achieved. So the likelihood of what comes back is often the indolent lymphoma. And we see this sometimes with things like transplant. I had a patient who, I have her, she had follicular lymphoma, then had treatment, then she had a relapse of the follicular lymphoma, got treatment, then she transformed, and we gave her a transplant for that. And then years later, that follicular lymphoma, that transplant, the aggressive transformed lymphoma went away, and she again had a relapse, but this time it was back to follicular.
Yeah.
So the aggressive never came back, and just the low-grade follicular, because follicular is not considered. So what we did at that time, we used CAR T for the follicular lymphoma. And there are treatments now which will attack both follicular and the transformed. So sometimes you want to harness that. So for example, Axicell is approved for follicular lymphoma. It's also approved for DLBCL. So when you use a treatment like CAR T, you're basically killing both. Ultimately, it's all coming from one B cell, and it may be transformed. But if you attack that B cell clone, then both the low grade and the high grade both can go away. Similar with bispecific antibodies, it would attack both. So many of the treatments we use now, especially some of the more modern treatments, have activity against both the follicular lymphoma as well as the transformed component.
So moving on to the next question, we've talked a little bit about this. CAR T-cell is a great new treatment, but as I understand it, it targets all B cells, which is correct, not just the cancerous one, leading to depleted immune system that can last a long time. Is there any current research on similar immunotherapy treatment that can identify and attack the cancer cells and not the normal B cells? Good luck with that.
Yeah, I wish, right?
No.
So, I wish that would be, something which we would love to have. Unfortunately, I think even in B-cell lymphoma, we are really fortunate that we have been able to identify antigens. Remember Dr. Favaro was mentioning those spikes, right? Imagine if those spikes were not just in B cells, and they were there in liver cells and heart cells and kidney cells. Then this CAR T would go and kill all of those, right? Which is what, fortunately, we can get away with CD19 being expressed only in B cells, but not in other normal tissues, not even on T cells, not even on other neutrophils or other parts of the immune system. So many other diseases don't have that. There is multiple myeloma, which has BCMA and a few other antigens. We are starting to work with some solid tumors which have these, but it's been difficult. Even in diseases like acute myeloid leukemia, you don't have things which are just specific for that cell. So if you, with B cells, you can, yes, you're more prone to infections, but you can still, get IVIG, which is a immunoglobulin supplementation, which can help reduce your risk for viral infections especially. But, we currently don't have spikes on the surface of just cancerous B cells, but are absent on normal B cells. We don't have, but that would be something which I hope future researchers can.
One thing I have to comment on that, going back to the low IgG, I believe there are other studies, and over time you have some B cell recovery.
Right.
So a lot of people, even though their IgG is low initially, will gradually recover, and it doesn't affect their remission rate.
Absolutely.
And secondly, like everyone is so unique, some people with low IgG can get infections. Some people do fine, because there are patients who haven't had CAR T-cell that have primary B-cell aplasia, and they do fine. And a lot of them don't need IVG. So it's just all human beings are different, and it's a case-by-case situation.
Exactly.
But I would say that what I've seen from the people I know on CAR T, most people have, had maybe some infection, but most people have been fine and living a normal life even without IVIG. So it's so variable, and I'm sure you have to see that with everyone.
Yeah, absolutely.
And the solid tumor CAR Ts that they're trying to make right now, I mean, that's the challenge there, is that finding the antigen on the lung cancer that won't damage or destroy your lung. And I think the fortunate part about lymphoma is that you can target those lymphoma cells. You will deplete your own B cells, that's true, but we'll mitigate that. It's mitigation. Prophylactic antibiotics, IVIG if needed, taking precautions, but still living your life.
Right.
You can do that.
Yes. So I think that's a good point. So, we're talking about risk. What are the overall risks as far as activities, food, et cetera, do post-CAR T patients have to avoid in remission? I'm going to tell you now, Michael, I don't avoid anything. And I have not been avoiding anything for many years, but I'm 8 years out at this point. But there are precautions initially because a lot of people have low ANC and some other depletion initially.
Right.
So,
So
so it
depending
really
where
is a
you are.
case-by-case basis, and I'm going to throw it to you guys because you can tell them some things you do.
Yeah. So I think, right after CAR T, blood counts are low. So, sometimes we even need to give growth factors to, improve blood counts. So there, the risk is going to be higher in terms of infections than a few months out. And if the blood counts recover, especially neutrophil counts recover, then, certain infection risks go down. Now, the B cells always take time to recover. So with the B cells, and even as the lymphocyte count recovery takes longer, that's where some viral infections and other things which masking, especially if you're in a crowded area, frequent hand washing, those are things which till the B cells have some recovery, your immune system is compromised, so that would be advisable. But as more time goes, then those restrictions start coming down a lot, and ultimately you have to live your life, but still be cautious that yes, if you do get an infection, then I think you're alerting your providers and trying to do some tests to just find out, is this like a thing which is mild, or is this something which needs to be worked up or treated, is crucial. But I think in terms of food, I don't think there is anything other than if you're neutropenic, you have to take certain precautions in terms of raw food and things like that while your neutrophil count is low. But once you recover that, then that typically happens in the immediate post-CAR T
Right.
phase. So if you are in that phase, then I think some restrictions. But as more time goes, those usually are not an issue. Yeah.
And it varies. And I would say one thing, after 2 years, I would encourage everybody who's watching to have an internist and maybe even an immunologist. You need to have a team that takes care of you. Your oncologist will move out of your realm because they have people who are very sick to take care of. And, so I do encourage everyone to get an internist or somebody who is really good that can take care of them day to day. So let's move on to the next question. Does CAR T work a second time if it didn't keep complete response the first time? So can you have a second CAR T?
Not commercially. So CAR Ts are approved just once in the commercial setting, but we have clinical trials which will allow a second CAR T. For example, we right now have a NK CAR T clinical trial using NK cells,
Natural
killer cells, which are modified to become CARs, or chimeric antigen receptor expressing cells, and they will allow, so on that clinical trial, we allow patients who have had a commercial CAR T and then have failed a commercial CAR T. Some of the allogenic CAR T trials, like from Fate Therapeutics or from Allogene, they will allow patients who have had a previous CAR T. Now, there are other CAR Ts which are coming out. For example, we have a CD19, CD20 bispecific CAR T, which we are about to open. And on that clinical trial, if someone, had commercial CAR T, that is probably not allowed because they have already failed CD19 CAR T. But let's say you have another clinical trial targeting CD22, and people have had the traditional CAR T. Now you are using CAR T again, but it's again different spikes.
Different spikes.
So if you're going against a different spike with a clinical trial, that would be doable. But if it's the same one, then likely not. So that's basically the general feeling for
trial.
And
So,
trial. The second time it's
in trial.
Unless a CAR T gets approved, which
never know.
allows your previous CAR T treatment.
Yeah. So next question. Understand we have several. I'm still unsure about some of the things I've heard more recently because I don't know if I have access to them, CAR T, et cetera. What about newer monoclonal antibodies? Do they still play a role? That's from Mike.
I can answer that.
Yeah,
There's definitely other options out there. So Monjuvi is a monoclonal antibody against CD19, and so that has been looked at in relapsed lymphoma in combination with lenalidomide or Revlimid. So that's an option. Also Zinlonta, which is one of these antibody drug conjugates. So this is a anti-CD19 that's bringing a chemotherapy payload with it. So it's going to attach to your CD19 spike and internalize the chemotherapy right into that cell. And so that's another great option, is IV every 3 weeks. And so these are two really, I think, good options for patients that, for whatever reason, the CAR T or the BiTE's not working or not available. These are options that are easily given off the shelf and approved by insurance.
Great. So, yes. So, another question. This is popular on my site. Cannabis and non-Hodgkin's lymphoma. Are there any benefits, or I would say risks? So who wants to take this one? Dr. Mata?
Sure. I mean, it's a it's a question that comes up pretty frequently.
Yes.
And I think a lot of, there may be some misinformation out there and some misconceptions of, prevention of cancer with cannabis. And I don't think there's any, founded data or anything of that sort. Certainly people, think about it in terms of symptom control and things like that. We do have medications that use the cannabinoid derivatives in a medical form, such as Marinol that we use for nausea, appetite stimulation for folks who've gone through chemotherapy and things like that. I think generally, cannabis, we discourage smoking of cannabis only because it's, there's a lot of additives that could be associated with it. When your blood counts are low, when you've gone through therapy, there's a fungal infection risk as well. And then, there's a lot of unregulated things that we just don't know what we're dealing with. And so I don't think there's any recommendations that can be definitely given. So I don't know that there are benefits per se, but I think it's a discussion to have with your physician about what works for you and what doesn't.
Yes. So, great explanation. Next, can you speak about the keto diet? Is it effective against cancer? Is it helpful in any way? Justin?
My general recommendation is the Mediterranean diet. And I think if you look at all the nutritionists and look at all the studies, you need several components to your diet. You need a small amount of protein, usually seafood. You need mostly vegetables on your plate, and then some whole grains for the carbohydrates. We feel like all these things are important. The keto diet really I believe it just takes out all the carbohydrates, since you're dealing with a lot of protein, a lot of fat.
Right.
And the downsides of that, for the rest of your body, let's think about, the cholesterol could go up, and that could be damaging to your heart. And if you look at, your body needs sugar and glucose. If you look at it, for example, let's look at a PET scan. What's taken up in the PET scan besides the lymphoma? It's your heart and your brain. And your heart and your brain really need sugar to work. And so you don't need sweets all the time, but what you need is complex carbohydrates, the whole grains, and maybe whole wheat pasta instead of white pasta. But that's only a portion of your diet. That's really about 25%. It's really the majority is your vegetables and maybe a lean protein. So that's the advice I've given. And if you look at some of the recent studies that come out that have looked at who lives the longest with cancer and what kind of diet do they follow, the winner seems to be the vegan diet. Actually, for that in terms of cancer survival and decreasing risk of recurrence. This is just cancer broadly, not lymphoma. But sometimes that's a hard diet to follow. So I think a Mediterranean diet is a reasonable, good diet for most people to follow. And it's probably the most common question we get as oncologists every day. What can I eat? What should I be eating?
Everybody wants control.
Yeah.
You want control over disease. I have to add something here. It wasn't asked. Exercise.
Yeah.
There were studies before, basically in breast cancer and prostate cancer, because they're so much more common and easy to study. Exercise helps. There was a study I know with breast cancer. I deal with a lot of breast cancer patients. That people who never even exercised before, if they walked 30 minutes a day after their therapy, they had a longer remission rate and cure rate with that exercise. So I encourage everyone to exercise. That doesn't mean you have to go and do CrossFit, and because that may lead to shoulder injuries. We also see that in radiology. But no, just walking, any type of walking, cycling, get yourself moving. And if you look at other studies, it's not only with the diet, people are active.
Right.
And people in Italy, for example, sort of live longer because they walk everywhere. They eat plenty of pasta, but they walk. So anyway, let's go to the next question. Another diet thing, does intermittent fasting help patients with follicular lymphoma or any cancer? And does sugar play any part? Another diet question.
Well, I think, intermittent fasting, there have been studies done, not just particularly in cancer, but that just shows that you're improving your insulin, you're improving insulin resistance essentially
Right.
with intermittent fasting. And I think at any point, when you have, dysregulation in your blood sugar control and things like that, that generally tends to lead to other medical complications. So I think definitely, there is some role to play in improvement in outcomes, I think. I don't know that it's been studied particularly.
I know, there's actually studies though with BMI.
Right.
People who are obese have a higher incidence of all sorts of cancers,
Yes.
and they have poorer outcomes. There's a lot of reasons for that. It's multifactorial, but eating healthy, exercise,
Yeah.
which is what doctors have, makes sense.
Yeah.
So let's move on here. Are there any strong evidence that our EPOC is better than R-CHOP for triple hit diffuse large B-cell?
I can take this one. So,
Yeah.
our EPOC used to be used for a lot more indications in the past than what is used right now. But for triple hit, which now is mostly double hit because the BCL6 translocation with CMYC translocation in the new WHO is not really double hit anymore. So, our EPOC is still considered as the standard for this disease based on a lot of retrospective data. So I think that this type of aggressive lymphoma is one of the most aggressive variants, and this infusional chemotherapy or EPOC with the etoposide added seems to be more what has become very common practice. There is no clinical trial taking patients with double or triple hit lymphomas and giving half of them R-CHOP and half of them R-EPOC. However, there was a large clinical trial which took all patients with diffuse large cell lymphoma and gave half of them R-CHOP and half of them R-EPOC. And R-EPOC was not shown to be have a better efficacy. It was similar, but it was not really better. So that study, was inconclusive in terms of the improvement for this double hit patients. But I would say pretty much if you ask most doctors, double hit patients will still be getting R-EPOC just because, there's a lot of good retrospective data showing better long-term responses with R-EPOC compared to R-CHOP.
Okay, so now, what questions do we have in the audience here? Does anybody would like to offer a question? John?
Yep. So we mentioned CAR T. We mentioned CAR T as well as complete response rates and durable remission rates following CAR T. With the much larger patient population, have you seen any trends emerge as to which patients, be it demographics, disease typing, HLA typing, anything, that seems to tend to do better with a better response rate, a better complete response rate, as well as a more durable remission with CAR T?
Yeah, so that's a great question, and people have really tried to figure out, it's always this thing, before you start a treatment, you'd love to know that this treatment, because there's so many treatments, that okay, this treatment is going to give long-term remission for this person versus someone else, this is the best. We are not there yet, but we have some ideas. It's not perfect. So with CAR T cell therapy, we know that if someone has very bulky disease, okay, and like fast-growing, really bulky disease, CAR T cell therapy is not giving similar, really great outcomes in that. Not that there is anything else which does, unfortunately, so people still go for it. But sometimes you want to debulk while you're waiting because CAR T is a several weeks process. So, for example, if there's one site of bulk, we often can do radiation, and there have been these new radiation techniques. One is called boom boom, where short, very effective radiation to shrink the tumors, perhaps even express all these antigens and have a better kill. But bulky tumors can often cause T cell exhaustion quickly, and so you are trying to give a load of these T cells, activated T cells, and then if they get overwhelmed with the tumor, then those T cells can really become, get immune tolerance. And there are also subpopulation of these T cells, which really, can cause regulatory T cells, which can cause an immune suppression. So, we actually are doing a study right now where we are monitoring different types of cells post-CAR T, myeloid-derived suppressor cells, different types of T cells, monitoring the cytokines and checking them at multiple times after CAR T to see if we can identify patients who might have relapsed and had one type of immune repertoire versus those who had long-term remission and have a different type of immune repertoire post-CAR T. So that trial is, that study is ongoing. Actually, it's just finished accrual at our site, and we presented the initial data at ASH, but hopefully, over the next year or so, we'll do a little bit more analysis on that and try to be able to, understand a little bit better that what may be the characteristics of a person, because we have samples also pre-CAR T. So what may be the characteristics of a person pre-CAR T which could predict a long-term response?
And maybe they would do better with BITE,
Maybe
who
they
knows?
would do. So we also have a study with BITE. We are doing it for patients who are getting mosunetuzumab, and we are collecting samples pre and post and trying to identify which type of T cells, they may be associated perhaps with a better response versus a not so durable response. A great question.
so-
Biomarkers.
Any other questions?
I think we have one right.
Please. We're going to get you a microphone.
Can you define CLL and how it complements follicular lymphoma?
Yeah, so CLL, I don't know if...
No, go ahead, please. Yeah.
Yeah.
Sure.
CLL is chronic lymphocytic leukemia. That comes under non-Hodgkin lymphoma. So CLL is circulating disease in the blood. There is a lymphoma component to it called SLL, small lymphocytic lymphoma. It's essentially the same disease. The SLL is in the lymph nodes, CLL is in the blood. So, if there is above 5,000 circulating lymphocytes, then it makes it as a definition for CLL. If it is below that, there is it's called MBL, just monoclonal B lymphocytosis. But at the end of the day, it's an indolent form of lymphoma, which is circulating in the blood, but could also be in the lymph nodes, in the spleen, in the bone marrow. And how it complements follicular lymphoma, they all belong in the same indolent non-Hodgkin lymphoma group, considered as, less aggressive. CLL particularly has tremendous progress where we have really given up chemotherapy. So that's where it's a little bit different. You heard about bendamustine and things like that. In CLL, we used to use that. So in the past, we used to think, oh yeah, all indolent lymphoma, we could use the same treatment. CLL is one area where we don't use chemotherapy anymore. We really have relied now on targeted inhibitors, BTK inhibitors, whether ibrutinib was the first generation, then acalabrutinib, and zanubrutinib, now pirtobrutinib, and then BCL2 inhibitors like venetoclax. So these have all come in, in either sequence or combinations. And now the other important thing, very recently, Lysocell just got approved for CLL. So lisocabtagene, which is Lysocell, was studied in CLL and it was very recently approved. So now you have CAR T available for CLL as well. So, but as you can see, targeted drugs and immunotherapy. Chemotherapy was FCR and BR. We don't really use those anymore. They've been shown to be inferior compared to these newer drugs which we have.
So I think we're getting to the end of our time here. Any other last questions? I can do one more.
Is that
Thank you very much for being here. Really, really appreciate it. We also want to thank all of our sponsors, Atrium Levine Cancer Institute, the Leukemia Lymphoma Foundation, Hope Cancer Ministry, and also GenMab, AbbVie, and Insight for their support. And we really, American Cancer Society, Lymphoma Coalition, Livestrong Charlotte, and of course, Patient Story, really thanks you for this opportunity. This will be recorded. You'll be able to see it online. And thank you so much for being here. And before you leave, guys, please complete the survey. Thank you so much. Have a wonderful day. Oh, I'm supposed to say something else. Interviews, you actually can view the story online at the Patient Story. There's also many other stories. There's my story online. I'm sure you really want to see that. And sign up for our newsletter. It's fantastic. And thanks so much. Thank you, guys.
Thank you. Thank you so much.
you.